Hi friends, welcome to paper 2. The same RJHS thing. So paper 2 of medicine is more of subspecialty and super specialty. So you should know what you are studying before what is there in the paper. So if you see in a broader way, what are the topics which are there? So the first important topic which you need to study is about the respiratory system, which constitute for 19 marks. Though they have given 9 marks and these are like interchangeable. Then you need to study about the central nervous system, which constitute for almost about 18 marks. Roughly divided into these parts as per the blueprint given by the university. Then the most important thing is the infectious medicine. Though the overlap with micro is considerable here, but infectious medicine is a super specialty subject. So and obviously you cannot go without reading dermat and psychiatry. And sometimes in previous year paper this is also as per a 10 marker, so I have to give a disclaimer here. And nephrology and geriatric medicine or family medicine. So this is like the portions which are there for your paper 2. So based on this we'll see how to approach the whole paper. So the same thing how we are done for paper 1. So if you see the most important our a major aim is to predict LAQ and SCQ, so that we get somewhere near to 6 we can predict up to 60 marks, and you can manage the remaining paper based on your previous knowledge what you had. So basically if you see the most important or most weightage part, so that is RS, CNS, infectious medicine, and hemat. So these are the questions in RS, which are possibly you can expect for 10 marker. Okay, so you can get pneumonia, most likely a community acquired pneumonia kind of case, and bronchogenic carcinoma and asthma. I'm going to explain you the management of asthma in detail as per the Davidson, and also bronchiectasis can be asked for 5 mark. But CNS, the most important 10 marker which you need to study is about stroke. Okay, so in and out of stroke you should study. Then infectious medicine, the nature of the subject itself is unpredictable, for because of the fact that they can ask you many questions, but for 10 marker it's very limited. HIV alone can be asked for 10 marker, or malaria, dengue, enteric fever. These are some of the uh, diseases where you have content to write for 10 markers. So I think these are the diseases, but you can expect any other diseases in these three, but make sure you finish these things. And short essay question, yeah. First thing which is there is about the hematology part. So you need to know about the anemia part. So mostly they're testing your concept based on anemia here. It's either your microcytic or megaloblastic anemia, and also the hemolytic anemia. And they have also tested ITP and hemophilia. Though it's a topic of pediatrics, it's being tested here. And make sure you know that. One question from HIV related, one question will be short, provided it's not a 10 marker. But here, if it was not a 10 marker, then sure, one question from HIV has to come for 5 marker. It might be something related to classification, opportunistic infection, which we'll be studying. One question related to dermat and psychiatry is sure for 5 marker. And these are the questions. Sorry, this has to be under this heading. Okay. So under dermat you have psoriasis, eczema, pruritus or scabies, and psychiatry also you have these many conditions. So you need to study all the questions which they had asked. And CNS for sure you'll get a question based on your headache, or SAH, or meningitis, or status epilepticus. It depends because 10 markers as a stroke is already been asked. There are chances that they might ask meningitis, but as per the blueprint given, this is the thing which is asked. So make sure you study that first, but be prepared to write. See, I will come to that part. Then nephro related one question is for sure. It might be either nephrotic, nephritic, or AKI, CKD, or EDPKD, which will be explaining. And also infectious medicine. As I told, infectious medicine can be broadly classified into 3 types. One is something to do with HIV, something to do with STD, and something to do with normal infections. So something to do with STD or PUO is like most important for 5 marker, or a CNS based on what is the 10 marker is what we are expecting in 9 question. Then 10 question is something to do with RS itself, because the weightage of RS is huge. So something related to RS will be asked, most likely the management of asthma or TB or pneumothorax. These are the questions which are asked. So what I am saying is there might be topics which can be interchanged. For example, some like fourth question can come as a second question. So I'm not saying the number is same, but these are the consistent pattern which they are following. So make sure you know this thing properly and study this thing. Okay. And 3 markers, yes, as I told, the aim is to test how long have you gone for, how much have you studied in the clinic. So only cause related things or any syndrome related things or drug related things is something which they test. Though here pre and paraclinical knowledge testing is limited as compared to paper one, but clinical rounds or clinical ward discussion is what they are focusing on. Though this is one topic which people will forget, but it's a short remarker, and these remaining things we'll be discussing, and MCQ for 10 markers. So this is in total what is there in paper 2. Paper 2 portions are too much than paper 1, I agree, but you should know how to plan your day a day before exam. So if you study in these order, you are in a safe position is what I feel. So these are the portions, and this is the prediction what we have. Based on this, we'll start with our discussion as usual. So first thing which I would like to say is we'll start with nephro. Though AKI and CKD are the major things, so I even feel that glomerular disease like nephrotic and nephritic can be asked for 5 marker, and also indication type questions or causes can also be asked for 3 markers. So this is what in broad I just wanted to say. So what I would like to say is, though nephrology has less weightage, one question is sure for 5 marker and one question is sure for 3 marker. Okay, so finish that question so that you have the confidence to go about. And nephrology has a easy flowing pattern. So it's so firstly I'll just give you an overview for that. So yeah, so if you have the kidneys, any diseases in nephrology can be like pre-renal, renal and post-renal. So based on this, you have concepts of AKI CKD based. Then based on the anatomical anatomy which is there in the nephrons, that is glomerulus, which I'll be explaining further, that is this part. Yeah, this part. So remember, this is the concept. Nephritic is infection. So what is getting infected? It's inflammation of the glomerulus is nephritic syndrome. But in nephrotic syndrome, broadly the filtration barrier is affected. See, for example, if you see here MCD, as I told, it's a effacement of podocytes, and FSGS, what is getting sclerosed? The podocytes are getting sclerosed. Okay, then membranous nephropathy, here the GBM which is there, no, the podocytes are getting affected here. So make sure you know these things. And diabetes or SLE or HPV, these also affect your nephrotic syndrome. That means the podocyte component. But whenever you come for nephritic syndrome, here if you see, it's all immunology. That is, you might have infection or autoimmune conditions. So make sure you have these concepts in mind, so that you need not think for any causes a day before on the day of exam. So this is like the general thing which you need to have. So based on this, let us jump to the answers on how to write an answer. So ARF, types of AKI, as I told, AKI and CKD has to go with classification like pre-renal, renal, post-renal. So based on that, it can be a functional thing. See, pre-renal is functional. That means there is nothing coming to kidney. So you have to, it might be due to volume depression or heart is not able to pump properly. So these are the condition, and also due to systemic vasodilation and renal vasoconstriction. Know this and you just write down. And structural, so that for that you need to know what is there. So you have glomerulus, then you have the tubules, then the loop of Henle, PCT, loop of Henle, DCT and collecting duct. So based on that, it can affect any part. Glomerulus, that means in nephrotic, tubular, ATN or drugs, or interstitial, ATN or toxins, and AIN or for interstitial, that is this part, you have AIN, and vascular like migraine and hypertension. Post-renal is a major topic of urology. So there I would not like to discuss much, but these obstructive things like urethral strictures, PPH, and any trauma to urine is something which you need to know. So know the types of AKI. Then this is the definition which you can study. Then the clinical feature depends on what is the type of AKI which is being presented. If it's pre-renal, obviously you know it's features of shock, renal, glomeruli, then due to toxins, then due to systemic disease. and also due to vascular thing. Know this part. And vascular, you have to just go with look for the distended bladder thing. Okay. Aim. So management, when I are discussing about management, you have to assess the fluid stages for pre-renal. Next, to know what is the cause, whether it's pre-renal, renal, post-renal, you have to do this. That is, you have to check what is the underlying cause. And major thing, any hyperkalemia in adults is CKD unless proven otherwise. So you need to know the management of potassium hyperkalemia. Then if there are any nephrotoxic drugs, you need to discontinue that. Then also if there are any intermittent infection, then you need to do that. So the same thing. So what are, so now you there are instances where you tend to forget few things. So what you need to do for that, first thing, you should know the statistics part. So with the most common cause of AKI is pre-renal first. So this should be returned first. Then you need to, second thing is you need to know the cause. So you will start writing how do you go with the cause. Then you will know what are the complications to expect. Then you will go with drugs and management. So these so whenever you are doing an investigation, first you should know what is the statistics, so that you know what you are predicting. First is history, I agree. Then based on that, you need to play with your statistic number. Then you need to go with that. Then you need to know the underlying cause. Then you need to know the complication and nephrotoxic drugs as well. Okay. The same thing applies for CKD, but it's an irreversible condition here. So if you ask me, divide it into systemic conditions, then same which I taught you there. So what are the most common cause? Diabetes, then hypertension, then primary renal and secondary renal, which I am sure you know. The secondary renal is nothing but the systemic part which is there. Then obstructive as well. So clinical features, there's mostly they are asymptomatic. At stage 3 or stage 4 you will have presentations, and also know about the critical staging, that is stage 1 to stage 2 they are asymptomatic. Then this stage they will start developing symptoms. This stage you need to plan for renal replacement, and this is like the full-blown stage where you need to go to dialysis. So whenever you are studying a classification, as I told, know why it has happened, because here it's asymptomatic stage, and here there will be presence of microalbuminuria. So it's an independent risk factor for cardiovascular health disease. Then here you need to treat, you are expecting complication and you need to treat accordingly, but here you have to plan for dialysis. Okay. Aims, again management, again you have to prevent the progression, so that is the first aim. Then major thing is you have to provide cardiovascular risk factor, that is it's an independent risk factor, so you need to start the patient on aspirin. Okay. And also you have to check for proteinuria. I think you know the problems of proteinuria already, but if you are expecting the microalbuminuria which is present, that means it's an indicator for your arterial component which is getting affected. So you need to study about that and limit the complication. You have to do electrolyte, and you have to prepare for RRT, that is renal replacement. And this is how you prevent proteinuria. You have to start with ACE or ARB, then fluid and electrolyte. As you know, in any part of medicine, any complication, you have to go with electrolyte or as metabolic acidosis component as well. Then major important thing, anemia. So whenever you have to think for complication, go back to physiology, know what are the functions of that organ, then based on that block those things and come to a proper thing. Then LVH is common because of the increased risk of CVD, and also most important thing is it's an pro-atherothrombogenetic state. Okay. Then you have to prepare for renal replacement. As I told, these are the biochemical abnormalities which you will see. I don't think there is a need to discuss. You can just go through this part. And complication, make sure you write all the system, and you can go with the explanation which is given here. Okay, screen the patient for hepatitis and HIV, which is the most important thing. Then coming to the nephrotic syndrome, as I told, the concept, the podocytes are getting affected, and the triad you have to remember, that is proteinuria, hyperlipidemia, and hypoalbuminuria. Then the etiology of the classification part, I have told you, divided into systemic and primary. In primary, I have told you, but MPGN has a mixed type, so make sure you mention that. But MCD, FSGS, and membranous nephropathy is something you have to mention. This is about the pathogenesis of MCD, because any nephrotic syndrome in kids is MCD unless proven otherwise. And these are the clinical features which is present, that is generalized edema or oliguria, and might be due to any underlying secondary condition in SLA as well as diabetes. These are the investigations. Again, while writing investigation to confirm the diagnosis, to look for complication. Make sure you write that. Then though you won't do biopsy, for theory and marks sake, you have to mention that light and immunofluorescence will have nothing, because it's not an antigen or antibody mediated disease. You are having effacement of podocytes. So know the concept, then fit it and go accordingly. Then management, first you have to write about the generalized, that is salt restriction, diuretics and ACE/ARBs. Then specific, prednisolone 2 mg per kg body weight. Then again you reassess after the 4 to 6 week gap. Then you have to do the same thing. Then again you have to consider any refractory case if it's not responding. Okay. Then supportive thing, again it's an hyperlipidemic state, so you have to put them on statin. And also you have to you are losing antithrombin too, so it's also procoagulant state, so you need to address these two components. Okay, so these are the complications. Major important thing, you have to write about hypercholesterolemia, thrombosis. Then there are less chances of progression into CKD, but to get marks you can write. Then also mineral component, that is bone mineral thing, will also get deranged. And also there is increased chance of infection. Glomerulonephritis is what? It's an infection or an autoimmune condition. Okay, so that is why you have PSGN or an autoimmune condition like SLE. And also IgA nephropathy, that means IgA is getting deposited. What is IgA? IgA itself is an antibody. Okay, so whenever you say antibody, blindly you can write it as nephritis. Again, clinical features, generalized and systemic. Make sure you write all these things. Then diagnosis, again, to confirm the diagnosis, to look for complication. But here I have not written, make sure you write that. And to confirm the diagnosis, again divided into screening investigation like biochemical and pathological. Though you don't do again the microscopy part of it for PSGN, so it's always good to write. So you will have the same subepithelial humps in electron microscopy, and you will have immunofluorescence, which is the mainstay of mainstay of all this glomerulonephritis, because it's an immune mediated reaction. Then management, again the same things, but here you have to mention about hypertension. Then you need to mention about the secondary cause and you have to treat it, because you have to give immunosuppression to that part. And also if there is a chance of going into CKD, and by writing complication, write it as acute and chronic and mention these two things. And so those are the things which you can expect for 5 marker, that is AKI, bar CKD, bar nephrotic or nephrectic. These are some questions which can be asked for 3 markers. 3 markers itself, the nature is unpredictable, but these are the questions which are there in Singi, and I have just picked up which are repeated more, and I'm just discussing because the portions of paper 2 is very huge. So definition, I am sure you can go through it. Make sure you draw this diagram, and this is more than enough. I'm saying more than enough. And whenever you see causes of bleeding or immature causes of any blood loss in medicine, make sure you write what at lost, systemic cause at lost, that is hematological or something related to drugs, and divide it into renal, ureteric cause, urinary bladder and urethral. So that's something which you should know, and if you draw this diagram for 3 markers, I think it should be fine. Then ADPKD, yeah, this was as well as the 5 markers, so I just mentioned it here. So though the clinical features what you can give, what I have given is you can go through that part, but the major thing is you have to know the criteria part. This independently has the potential to come for 5 marker. So what is the concept here is as you age, the cyst, the incidence of you having normal cyst will increase. So from 15 to 40 years or 39 years, you should have either 3 unilateral cysts, and from 40 to 59 years you have to have 2. Then more than 60 you have to have 4. So this is something you can remember, but this is based on epidemiology and statistics, yeah. So I cannot make it much more easier. But important thing is, if there's a family history of HAH, then it's important for you to do MRNJ. Okay, that's important thing which you need to know. ADPKD, make sure you know the criteria well and go. Again, here you have to reduce the BP. That is the most important thing. And to reduce the EGFR decline, you have to give tolvaptan. Then renal replacement therapy, the major thing which they ask is about indication, that is AE, IOU. These are the OVELs. A for acidosis, E for electrolyte imbalance, I for ingestion, that is toxins, O for overload like heart failure, U for uremia. All the refractory cases you can go with renal replacement therapy. I have given the indication as well. Then what are the modalities for RRT? That is hemodialysis, peritoneal dialysis or renal transplant. And these are the complications. I'm sure you can just go through with that part. And hemodialysis, what are the types of hemodialysis you have? Either you have intermittent or continuous or sustained and low efficient or nocturnal. Okay, these are the complications. It's the same what I had written, and there are some specific indication for peritoneal dialysis, for example in children and neonate, if there is an hemodynamic instability where you cannot get access to your hand, and if there is a poor vascular status. Okay, Then acute pyelonephritis, yes, sometime they have asked for 5 markers, so I have just mentioned it over here. So obviously nephritis, so fever has to be there, then pain has to come next, then obviously tenderness. So investigations, obviously basic investigations, this is what something which you write for infection. So at the end, what is your aim is to, for all kind of, whenever there is infection, you should have few screening things in mind. Whenever there is inflammation, you have a few things in mind. Whenever there is neoplastic, you should have few investigation in mind. Based on that, you have to just keep on adding things and you have to build the concepts. Okay. So here culture obviously is gold standard, that even Dom, Dick and Harry knows it. Again, treatment, you have to give antibiotics for, that's for like sure. Here, based on the statistics, few organisms have been isolated, then based on that, sulfaxacillin or ciprofloxacin is the drug of choice. And if there is a abscess, you have to drain the abscess. You cannot give antibiotics with abscess. What does Bailey and Lowe says? If you see an abscess, drain it. Okay. Then Benz-Jones protein. Again, this is for 3 marker. Where will you see any plasma cell dyscrasias like multiple myeloma, and then lymphoma and light chain deposition disease. And proteinuria. This is something which is very important. Whenever you see a microalbuminuria patient, please refer to cardiologist. Okay. That means you have to control BP, but if you cannot, then you need to. It's an independent risk factor which shows, though it's in urine, it will predict heart health. So it is seen in diabetes, hypertension, and early glomerular disease. Proteinuria, again, divide it. Glomerular, tubular, overflow. So in that also you have selective or non-selective in MCD and PSGM. Here again acute tubular necrosis and also in multiple myeloma. Renal osteodystrophy, sometimes they have asked. So it's due to the calcium and phosphate metabolism which is getting affected and affecting the bones. Okay, clinical feature is bone pain and fracture, nothing else. Importance, they have asked for 3 markers. So know the etiology part well. You can divide it into organic and others. So others you can write surgical causes like Peyer's disease and also psychogenic part. Okay, and also in organic you can divide it into vascular and neurological and hormonal, which is self-explanatory. Then urinary cast treatment also, I think there's nothing need to explain. No need to explain. So you can just go through this part. Urinary cast, as I have discussed, is the same thing. Hyaline cast, cellular cast, granular cast, and fatty or waxy cast. So remember what are the types of cells which are seen in 11th standard. Based on that, you can extrapolate and write. So that's it for renal part of it. So while going, make sure this is a potential 5 marker or a 3 marker question. That means you'll get one question for sure for 5 marker and question for sure for 3 marker. So 5 marker, what are the things I have to study? I have to then that is AKI, CKD, nephrotic syndrome, nephritic syndrome. Then you have to study about ADPKD, then acute pyelonephritis. 3 markers. The nature itself is unpredictable, but you can always study about hematuria, renal dialysis, and indications for renal transplant. So that's it with nephrology. Make sure you study these things a day before exam and you go. Okay. Next part is about the geriatrics part. Why did I take geriatrics? Is the fact that people don't study this part. They just go and write it on their own. I have made it kind of in a good presentable way so that you don't lose marks in 3 months. So one question which they ask is false blindly. Don't jump and answer only 3 cause. Divide it into intrinsic cause and extrinsic cause. Extrinsic cause is due to environment. That is all these things, which is also a potential risk factor for you to fall. Okay. Then intrinsic might be due to gait and balance disorders like Parkinson, muscle weakness, and some drugs like sedatives and antihypertensives and postural hypertension. Polypharmacy, just know what is it. That means you're adding more drugs. That is more than 5 drugs for a duration of 3 months. So know this criteria. That's more important. Treatment is, you can understand. Dementia, it's a potential 5 marker. It's an overlap question. That's okay. It's an overlap question. For 5 marker or a 3 marker. So no, it's overlap between CNS, psyche, and geriatrics. Okay. So make sure you know that part and then go. So divide it into infective cause, then inflammatory cause. So that's why importance of Robbins comes here. So first lesson what I studied was infection, that is HIV or the prion disease. Then comes is inflammatory, but here you don't have any inflammatory causes causing dementia. So next is ingestion, that is toxin or nutrition. Then any reversible condition. Then also you have vascular dementia, traumatic in SDH, and also degenerative conditions. Delirium, this I have copied from worksheet below. It's just for 3 markers. I don't think there is a need to explain this part. So you can just refer this and go. Okay. What do you do? Make sure you know the causes well. Okay. Again, whenever you're writing cause, infectory, metabolic, traumatic. So I think you'll have that pattern. So coming to SAH part, so we are starting with CNS now. So in geriatrics, make sure you study these three questions, and that's more than enough. But for dementia, make sure you study much more, because it's an expected 5 mark question as well. Coming to the CNS part, I feel if you study CNS properly, infectious medicine properly, and respiratory system properly for paper 2, you are eligible to pass. Okay, based on that, let us jump to the topic, because we surely don't have time. So first 5 marker which is potential to ask, which has the potential to ask, is SAH. So that is, there is bleeding in SAH, that is a subarachnoid space. Etiology always divided into traumatic and non-traumatic, because here infective condition is less, because infection doesn't cause bleeding in this case. So based on that, you have to write all this. While writing clinical feature, make sure you write the same thing which I have mentioned. So coming to the template of CNS, no, while writing clinical feature, make sure you have to write if it's an infective cause, you have something already in mind to write. Then also signs of meningeal irritation, then any neurological symptoms, then any sensory symptoms, then any motor symptoms, then any autonomic symptoms. So based on these categories, if you broadly divide and write, disease will start fitting into places, and also you will know how much clarity you have in diagnosing disease. So again, this is the major thing, this which even everyone knows. Then there will be signs of meningeal irritation, because it's a close differential for meningitis, and also these are the neurological symptoms, and these are the autonomic things, symptoms which is present. So this is the investigation part which is there in Davidson. So I've just copied that part. So what you do is you have to do an emergency CT. So you might find evidence of SAH, or you might not find evidence of SAH. So if you do not find evidence of SAH, after 12 hours, it's your duty to do a CSF analysis to look for xanthogromia. So if it's present, then you have to treat like SAH. If it's not present, then you have to exclude other things and treat the underlying cause. So if you, whenever you diagnose SAH, you have to start with nimodipine 60 mg. Then you have to refer to the neurosurgery to look for the other part, that is coil insertion or surgical clipping. They will do based on whatever, based on the patient age and things. So make sure you know this, that is nimodipine and platinum coil insertion. But also know the complication, that is fluid, because you're playing with blood. ICH, it's also an important 5 marker, can come as 10 marker is what I feel. So again, definition, there's nothing to explain, and these are the etiologies. Then clinical feature, as I told, this is one thing which I forgot to say you, that is raised ICP signs wherever you can see. Okay. And also whenever you are mentioning about ICH, since it's a bleed anywhere in the brain, so based on location you can explain things. For example, if it's seen in basal ganglia, you will have hemiparesis and gaze deviation. And if it's thalamus is a sensory restriction. So all sensory things you can write. And points, obviously you are affecting your brain stem, so you will have pinpoint treatment. And cerebellar, that function is to maintain balance, so you will have ataxia and vertigo. So this is the diagnostic algorithm which is given in Davidson. I've just written that. So whenever you come, so you do the neuroimaging. I again differentiate between hemorrhagic or ischemic. So if it's ischemic, obviously you start with nimodipine and lower the BP to less than 140 mg, but not immediately. Then ischemic, then again you have to check whether you have the capabilities or the PCI center in your nearby. If it's yes, then go for IV thrombolysis. If no, then I have to start with aspirin. These are the risk factors. Again, while writing risk factors, make sure you know systemic factors and general factors and systemic factors. Based on this, these are the risk factors which is present. Make sure you study. Investigation, again, to confirm the diagnosis, to assess the cause, to evaluate for complication, to plan for management. This is like the basic thing where we are going to, based on this template, whenever you start writing based on this template, the investigation automatically will fall into place. So there's nothing which I need to do. Okay. The complication here are electrolyte, and any medicine person who has studied medicine will know. Again, one important thing is to look for cause. You have to do a echo here, because you have to check for where is the thrombi coming from. Okay. Now, I mean not thrombi, but whether there are any cause. Then how do you manage? These are the aims. For 10 marker and 5 marker, I told you have to know the aims. First, what are the initial things what you do, then definitive things, supportive things, and react. Okay, first you need to identify the cause based on your investigation, then assess what is the damage, then prevent complication and reduce recurrence. Okay, for that what you give aspirin and clopidogrel. So these are the reperfusion thing which you need to know. Make sure you mention about rehab. Okay. Then pyogenic meningitis. Before that, let me show you this table. Yeah. So this is the Davidson table which is showing you about the causes of meningitis. They are divided into infective and non-infective. That is sterile meningitis. And again, it might be due to malignancy or inflammatory diseases. Okay. Then again, bacterial, virus, and fungi. So these are the causes which you need to just go through that. Then based on, because bacteria are the more common, so here you have again neonate, preschool, and older adult. And specific to meningococcal, because it was a common thing. These are the complications which you can expect. So based on this, so what happens in meningitis is that, so if this is the brain, so either you might get it hematogenously, or in the traumatic case where the bacteria will come and multiply here, but it is a closed space, only it will allow three things to have, that is blood, brain, and CSF. If anyone gets increased or decreased, then you need to know what is happening in each case. So then again, coming to the pyogenic meningitis part, so again go with the definition and etiology. I would recommend you to see the Davidson table which I mentioned. Then pathogenesis, as I told, it might be either hematogenous or direct spread. So based on that, you will have host cell response and also inflammatory part. Then these are the consequences. That is, you are going to write the complication part. And again, the same thing for clinical features which I told, classical triad, features and complication to specific organism. For meningococcus, you have to mention about rash, though this is not commonly seen. Then these are the signs which are present. Then these are the investigations which you do. Basically, you will do with to know the etiology. You go with culture and sensitivity. To know the to diagnose it, you have to go for CSF examination or neuroimaging. These are the complications divided into neurological and systemic and long-term sequelae. People miss this, but make sure you write this. Okay, and this is something which is important. Treatment aim to start the empirical antibiotics to provide supportive care and to prevent complication. These are the age-wise thing which is there in Davidson, I have just mentioned. But while writing about the management, if it's as for a 10 marker or a 5 marker, it's better to write about prevention, that is vaccination and chemoprophylaxis. If there is a contact, then you have to give rifampicin, okay, or vaccination part of it. Then also talking about the TB meningitis part. This is the algorithm which is given in the CNS part. Okay, so need to know about that and then decide on how to go about. That is how to resuscitate and stabilize the patient. These are the initial steps, then initial management. Then what are this I'll come to it, or contraindication of LP, or if it's there, then why will you go for neuroimaging. And this is what is given in Davidson, but it's quite problematic to remember the whole thing. So you know what you are, so just write it broadly. Okay, that's what I would say. Again, for TB meningitis, it's the same thing, but clinical feature is little change. And also for diagnosis, you go with AFP and chest X-ray or CT. Then in CSF study, you will have that increased lymphocytes also. Then cobweb appearance, all those things. So that part I think I have mentioned here, if I'm not wrong. Yeah, clinical features and staging of tubercular meningitis. Make sure you write all these things. That should be enough for your meningitis. Meningitis is an important topic. Make sure you go and study. This thing I have applied here because of the movement disorders which are present. Okay, that's an important potential question for hypokinetic and hyperkinetic disorders. So hypokinetic, these are the things, and hyperkinetic, these are the things. Okay, just make sure you know that part.